Hello, I'm Dr. Chris Link. I'm a functional medicine physician in Jefferson City, Missouri. And I'm going to post this video, which is from a conference in which I presented about a month ago to primary care providers on the treatment of osteoporosis. I particularly have an interest in this area to treat osteoporosis in the very best way. And this is a discussion on the integrative and functional medicine approach, which really uses all modalities and treatment options to improve bone health, to include exercise, nutrition, supplements, and medications when needed in a very safe manner. So if you're interested in this, either as a provider or a patient that has osteoporosis, I think you'll find some important information here. I hope it helps you, and I wish you the very best of luck in the care of osteoporosis. Thank you.
An overview of the talk. We'll talk about the significance and impact of osteoporosis. I found out long ago that all of my patients have bones, and many of them that are 50 and older have some trouble with bone density. So just to be a little light there, this is an important topic. We'll talk about the current status of screening and treatment. We'll look at the laboratory assessment for the initial evaluation and the laboratory and screening and imaging for the ongoing monitoring. We'll look at optimal pharmaceutical management. We'll look at the safety and effectiveness of these and side effects. We'll look at the concept of medical mindset. What do our patients need to know from us so that they can make the best decisions based on the way that they perceive what's important to them? This is very important in regards to helping patients understand the best treatment and to make the best decisions for them. Lots of communication is needed in the treatment of osteoporosis, as we'll see, and along with many, many other conditions we treat. We'll look at additional therapies. This is really the integrative part of it, where we're going to look at how nutrition and supplements and exercise can really impact bone health. And when people are faced with osteoporosis in their life, they tend to really start to think about what else they can do, and it's a real opportunity to help them improve their overall health, not just their bone health. 1 in 2 women age 50 and older will have an osteoporotic fracture during her lifetime. It's predicted in 2025 that there will be more than 3 million osteoporotic fractures, $25 billion worth of healthcare costs, included clearly a major burden for disability, quality of life, pain, and even early mortality. The healthy bone on the left has thick and numerous strong trabeculae. On the right, the osteoporotic bone not only loses the amount of trabeculae, but the ones that are left are thinner. This bone cannot support loads nearly as well as the healthy osteoporotic bone on the left. This lady who clearly has osteoporosis and kyphosis, she has a significant change in her pulmonary function because her thoracic cavity related to the vertebral collapse and fractures has decreased in size, so her pulmonary capacity and function is lowered. Her whole rib cage is actually decreased and descended into her pelvis. It's closer to her pelvis, so her abdominal cavity is limited, so that may impair digestion. And clearly her overall structure with these changes make it much more likely to fall. And with all of this, she has a predicted earlier mortality. Osteoporosis is significant. It makes a big impact in people's lives, and we can do some things to improve it for sure. But there are significant care gaps. This is published in the Best Practice in Research in Clinical Rheumatology 2022. They report that osteoporosis is indeed very common, and it's a leading cause of disability and mortality. Osteoporosis care has evolved. We have good definitions. We have validated ways to assess this with DEXA, and we have terrific pharmaceutical medications that can make a big difference. Effective medications that can be used safely. Despite this, there is really a large treatment gap. That is, the majority of patients with osteoporosis do not receive adequate identification or screening. And it's known that a person who's had an osteoporotic fracture is at significantly higher risk. And even these patients, as I'll show you in the next slide, the majority are not treated for osteoporosis. This is a paper, an abstract actually, from the American College of Rheumatology, November of 23, so very recent. This is on the current trends in the risk of a subsequent fracture after an initial osteoporotic fracture. Retrospective study, women 50 and older, from 2012 to 2021, nearly 500,000 women with an initial fracture. They noted that in the first 12 months after the fracture, there was an 11.6% chance of another fracture. In the next 24 months, a 19.1% risk. They went on to report that most patients did not receive pharmacological therapy during the first year, 91.7%. And 89.4% did not receive osteoporotic care in the first 2 years after the initial fracture. That's a lot. So what they said in essence is that post-fracture treatment was only 8.3% in 12 months and 10.6% at 24 months. This is really abysmal. We can do better than this. The conclusion, clinical guidelines specify that osteoporosis is a lifelong chronic disease. Recent data over a 10-year period show that recurrent fracture rates within 2 years are high, and pharmacological treatment is underutilized. Why are treatment rates low? Why are treatment rates low? I mean, all of us know that this is important. There are many things that factor in. There's a failure to diagnose. That is, we don't always make the diagnosis and then move to the treatment. There's a lack of DEXA screening. We'll talk about this more in just a minute. There's a failure to recognize that if a person has a fragility fracture, that in and of itself, despite what the DEXA says, makes the diagnosis of osteoporosis so we can treat those patients. There's a failure to offer therapy. We're not offering therapy. And there's insufficient number of osteoporosis specialists in the community. So it really falls more on primary care providers. And then treatment is offered but declined. And there's lots of reasons for that, but there's much fear based on what people have heard from their friends or on the internet about potential side effects. And helping them understand the risk-benefit ratio is what's the likelihood of those side effects and what's the likelihood of having a significant fracture that may change their life, lead to disability and chronic pain. And I think for many patients, they don't have the proportions of this really understood so that they can make the best decisions for themselves. And then treatment is often discontinued. So primary care providers, all of us, are uniquely positioned and qualified to effectively diagnose and treat osteoporosis. We can do a great job at this. Understanding the condition well, the treatment options, and understanding the concerns of each patient allows us to help with better compliance and improve patient outcomes. We got this. We can do this. This is a condition that primary care providers can do an excellent job in making a difference for their patients. Just like the treatment of hypertension or diabetes or arthritic conditions, depression, we can make a difference here. So let's move into the screening guidelines. And this is the ACE guidelines from 2020, so the most recent guidelines. They recommend that all women 65 years and older get a DEXA scan. That postmenopausal women with a history of fracture without major trauma, that is a fragility fracture, or if we see osteopenia on x-ray, get a DEXA scan. They go on to say that there's many other reasons we can get a DEXA scan, including women that are perimenopausal or postmenopausal with low body weight. They're at increased risk. If they're going to start a glucocorticoid, say for polymyalgia or rheumatica, and they're going to be on it for a while, or another autoimmune condition, or if they've been on glucocorticoid therapy, if they have a family history of osteoporosis, if they've had early menopause, history of tobacco use, excessive alcohol use, and other medications that can be harmful to bone, and that's in the upper right there, things like aromatase inhibitors, corticosteroids, Depo-Provera, PPIs, SSRIs, and warfarin. And really what it means is that as a clinician, we have wide clinical latitude to offer screening to patients. So what do you think is the percentage of women greater than 65 that are actually screened by DEXA? Well, it turns out that it's less than 50%. DEXA is safe, it's inexpensive, it's accurate, reproducible, highly correlated with fracture risk. That is, a 1 unit decrease in the T-score doubles the risk of fracture. And the effective dose of radiation is exceedingly small. A mammogram has about 0.1 millisieverts, a chest X-ray 0.4, and a DEXA 0.01. So it's 10 times less X-rays radiation than a mammogram and 40 times less than a chest X-ray. So this is very safe. The key sites we look at is the lumbar region, L1 through L4, the femoral neck, the total hip, and the distal third radius. The FRAC score, and we'll talk about this in a minute, looks primarily at the femoral neck. The newest guidelines will look at the lumbar as well. And with treatment, we should follow up every 1 to 2 years. Now, interestingly, Medicare will cover a DEXA every 24 months, but it also states that more frequent when medically necessary. So in cases of hyperparathyroidism, chronic kidney disease, or active osteoporosis treatment. So we can clearly do it at 12 months for that. And even if a patient would have to pay for this, say their insurance would cover, and we think it's clinically beneficial, these cost about $150 now. So this looks at the change of T-scores over the lifetime. So at age 50, the average woman is going to be -1. Of course, she was 0 is the standard when she was 30 and had her full bone density. And at age 50, she'll be -1, or the average woman will be. And the average woman will have osteoporosis, or a -2.5 T-score at age 75. You know, we talk about starting the screening at age 65, but we see that there's a big drop-off here at menopause. Should we start the screening earlier? And I think we should, because if a person starts with a low score here and then is going through menopause, she's very likely to have premature osteoporosis. And this is where the integrative approaches, the nutrition and exercise, weightlifting, appropriate supplementation can make a difference, and she may not need medications. And in fact, this is a place where, you know, at menopause, that hormone replacement therapy can be very effective and is FDA approved for the prevention of osteoporosis. We'll talk about that more in a minute. Diagnosis. So who needs treatment? If a T-score is -2.5 or below in the lumbar spine or femoral neck, that would be an indication for treatment. If they have a low trauma that is a fragility fracture of the spine or hip, regardless of the bone mineral density, that is meets the diagnostic criteria for osteoporosis, and that would potentially benefit from treatment. And then if the FRAC score, and we'll look at that in a minute, if there's a greater than 20% risk for any osteoporotic fracture, or a greater than 3% risk based on this tool, I bet many of you use the FRAC tool, that's also an indication. Forearm bone mineral density, when is it important? The forearm bone BMD can be used to make a diagnosis of osteoporosis when the spine or hip BMD cannot be reliably interpreted, and in conditions of hyperparathyroidism, which I'll mention right at the end here. The hip or spine may not be measured in the following circumstances reliably: if there are hip replacements, or if there's spine surgery with hardware, if there's severe osteoporosis in the spine, which can falsely raise the BMD, if obesity above the limits of the DEXA table, then we'll use the forearm BMD. If performed prior to the upper extremity orthopedic surgery, so they're going to have surgery on their arm, we want to make sure that they've got good bone density in their arm. This is measured at the 1/3 radius, and you can see the arrow on the right, 1/3 up from the distal radius. Now, in the condition of primary hyperparathyroidism, which predominantly affects cortical bone, and in the wrist, it's predominantly cortical. So evaluating the forearm provides important information that may not be captured by just assessing the spine and the hip, which are richer in trabecular bone. Measuring forearm BMD can identify primary parahyperthyroid patients who meet surgical criteria for parathyroidectomy. One study found that forearm DEXA increased the rate of asymptomatic treatment by 5.2%. So you take a patient that has a marginally elevated calcium and an elevated PTH, They have reasonable bone density in their hip and in their spine, so they don't have that indication yet for surgery. But if they have profound osteoporosis in the wrist, that would be an indication then to remove the parathyroid glands. This is the FRAX tool available at that website above, and you can also Google it as well, the FRAX calculation tool. So it puts in things like age and sex and weight and other things like previous fracture, parent history of hip fracture, current smoking, use of glucocorticoids, and a history of rheumatoid arthritis, along with the BMD of the hip. And this will give you the FRAX score. And again, if the score is greater than 20% risk of any osteoporotic fracture or a 3% risk of hip fracture, that's an indication for treatment. There is a new tool called the FRAX Plus. And this also adjusts for the factors to the left, but then adds falls, recent fractures, diabetes, because diabetes actually decreases bone strength despite a decrease or not in bone density. The TBS score, which is the trabecular bone score that's available on the software of newer DEXA machines, that gives you a pixelated information about how dense and strong the bone is likely to be. So this is done in the lumbar spine. It also will use the lumbar spine BMD rather than the FRAX tool that uses the hip only, and the use of higher doses of glucocorticoids. So this can be helpful, but there is a fee to use this tool. So based on the ACE guidelines of 2020, this is the workup for secondary causes of osteoporosis labs that we ought to do initially when a patient presents with osteoporosis. CBC, CMP, vitamin D, phosphate level, a 24-hour urine calcium. And this is important because 5 to 10% of people with osteoporosis will have hypercalciuria, and there's things we can do to treat that, hydrochlorothiazides and other things. Thyroid, of course, look for celiac, and I underline that because I've seen this several times in my career where we diagnose celiac and it significantly improves as they eliminate wheat in their diet, the health of their gut absorption, and also the health of their bones. Look for an SPEP, so we rule out things like multiple myeloma, urinary free cortisol, tryptase for mastocytosis. This is very rare. I've never seen that. And of course, a PTH level. This looks at an overall review of the medications, anti-resorptives and anabolic therapies for osteoporosis, from the SERM raloxifene to oral bisphosphonates like risedronate, alendronate, Actonel, and Fosamax, IV zoledronic acid, subcutaneous denosumab, subcutaneous teriparatide, abaloparatide, and romosozumab. Now, the last three are anabolics, and romosozumab, Evenity is particularly interesting in that it has both an anti-resorptive capacity and also an anabolic capacity. So the 2-year increase in spine BMD for raloxifene is pretty low. As you move down to the oral bisphosphonates, it increases. The IV bisphosphonates even more. And you can see that denosumab is the strongest anti-resorptive at the spine. Then when we move to the anabolics, you get even more improvement. So that's something to keep in mind. So these are the basic categories of the medications that are available. The key is that any treatment is better than no treatment. As we talked about in some of the earlier slides, people are not getting diagnosed and they're not getting treated. So we have some work to do. And if it's such that a patient insurance will only allow an oral bisphosphonate, it really does make a difference. Though I tend to use some of these other medications more often, as I'll talk about in a few minutes. So more on the medications. The anti-resorptive medications, alendronate and risedronate, we can use for 5 years out of the gate, or IV zoledronic acid, which is used once yearly for 3 years. If there's an improvement, that is their T-score now is better than -2.0, then we can consider a drug holiday for these oral anti-resorptives. For denosumab, if the T-score is better than negative 1.5, we can consider making a transition. There are no drug holidays with denosumab, but there is with the bisphosphonates, and we'll talk about why that is the case with denosumab. You also need to get a little bit better T-score because you get a bigger drop-off in bone density when denosumab is discontinued, even if you follow that with an appropriate medication like a bisphosphonate. We want to continue therapy longer than 5 years for the oral or 3 years for the IV if the T-score remains less than negative 2.0 or if they fracture during treatment. So we could take the oral bisphosphonates to 10 years or zoledronic acid to 6 years. Denosumab until improved again greater than 1.5 years, and it's really not based so much on time. In an older person, it's possible that they may be on denosumab for the rest of their life. We can certainly give that longer. Denosumab tends to have less risk for some of the serious side effects. Not no risk, but a bit less than the oral bisphosphonates. So transitioning from denosumab, if transition is desired, you want to go to a bisphosphonate, either zoledronic acid IV or oral bisphosphonate for 1 to 3 years. Then you can consider a holiday from the bisphosphonates. The bisphosphonates then will lock in the benefits of denosumab. If you just stop denosumab, you get a rapid fall off. And we'll discuss this further in a minute. So the anabolics are for people with very high risk for fracture, and then that's defined as the T-score less than negative 3.0. The anabolics really do build bone. They thicken the cortex and they improve the structure and the number of the trabeculae. So more than just increasing mineralization. Teriparatide and abaloparatide are PTH agonists, and they're typically given daily sub-Q for 2 years. Romosozumab is given monthly for 12 months. These all require transition to a bisphosphonate, oral or IV, or DMAB afterwards. So if you're going to hang on to the benefits of an anabolic, you need to be giving something directly after its discontinuation. Sequential therapy. Say a patient has this high risk, worse than negative 3, then you want to start with an anabolic. Because if you give the anti-resorptive first, like some of the insurance companies want us to do, try the less expensive bisphosphonate oral or otherwise, it will diminish the benefit of the anabolic. So the best option is to use the anabolic first for very high-risk patients. That's sequential therapy. Note that the black box warning for teriparatide related to osteosarcoma has been removed in post-market analysis for more than 20 years. There is no increase in osteosarcoma in women higher than baseline, what would be expected in the population. A note about DMAB or denosumab is it's not cleared through the kidney, so it's safe in renal insufficiency. Zoledronic acid and denosumab are the medications I tend to use most. I find them to be the most effective and well tolerated in patients, and it helps with compliance as well. There's some issues with daily or weekly or monthly compliance of the oral bisphosphonates, and then of course they can exacerbate some GI issues like esophagitis. This is a lecture from Ben Leader, who is indeed a leader in osteoporosis management from Mass General Harvard. You can see the YouTube link there. And he has a nice 30-minute lecture on sequencing of osteoporosis medications. I'll give you links to several other lectures that I've used to learn myself, and then also conferences that I attended to where some free lectures are available as we go forward here. Hormone therapy. So hormone therapy, estrogen itself, improves the function of it lessens the activity of the osteoclast, and it increases the function of the osteoblast. It inhibits absorption. The Women's Health Initiative, which was the biggest study ever done in medicine, like $1 billion study that was completed in 2003, but has had subsequent analysis for many years, has shown that there was a 34% risk of fracture in women that were taking the hormonal therapy. And estrogen therapy is approved, as I mentioned before, for the prevention of osteoporosis. This is a JAMA article. September 2017, menopausal hormone therapy and long-term all-cause and cause-specific mortality. In short, it is effective and safe. Among postmenopausal women, hormone therapy, and here they use, conjugated equine estrogen instead of the estradiol bioidentical that we all would typically use for a patient these days. For a median of 5.6 years, or CEE alone, for a median of 7.2 years, was not associated with risk of all-cause mortality, cardiovascular, or cancer mortality during a cumulative follow-up of 18 years. This is important. We can safely use these medications in our patients with premature, significant osteopenia in menopause, early menopause, or osteoporosis, or these can be effectively used and safely used. Let's talk about the medical mindset of patients, because one of the things we heard early on is that there are lots of reasons patients don't get treated, both because medicine is not diagnosing it enough and not offering therapy enough, but even when they offer therapy, it may not be used by the patient, or it may be discontinued. So we need to understand what's important to the patient. Are they a maximalist in medical, in their mindset? That is, they're proactive and they want to stay ahead of the curve. These patients are more likely to accept medications, and they may be more likely to accept a medication that requires like daily therapy, like an antibiotic. Or are they a minimalist? Would they prefer to avoid medications? Do they like things more natural? They may not choose to use it until they really need it, and that may mean a significant fracture in their life. They may choose to wait. But if they're open to medications, they may be open to medications that require less frequency, and that may be better tolerated for them. So maybe the IV yearly zoledronic acid may be a better choice. So we really need to understand where our patients are coming from, what's important to them, what would work for them. So framing it really does matter. So we could say something like, we have several different treatment options, and the choice depends on your preferences or goals. That is, the patient's preferences or goals. Is it more important for you to achieve the very best bone density and fracture reduction, even if that would require more involved treatment like the daily anabolic? Or is it more important that you take a minimal approach and medication infrequently to reduce your risk of fracture? So we want to get an idea of those. And some of those people may choose not to be treated right away. They may choose to use some of the integrative approaches I'm going to talk about in a few minutes. We want to have a variety of things. We want to listen to the patient and find out what can work for them. We want to be patient with them. They may not choose to take the medication right out of the box. When I learned about this book by Dr. Groupman and Hartzbend, it really helped me understand that I need to listen to the patient, understand where they're coming from, obviously, but also understand they're not always going to take my suggestion to use medications if I thought those were necessary. So I need to have other options, and I need to work with them and give them information and let the best information I can to really help them understand the risk and the benefits and let them make their decision. Let's look at bone turnover markers. So these are helpful, and I'm using them quite often in my practice. The first one is the serum CTX, and this is the C-terminal end of bone collagen. You test it in the morning, fasting. So one of the things to take from this right away is that there's a lot of collagen in bone, and when we talk about what else we can do to support bone health, we're going to talk more about collagen. If the CTX is less than 300, it supports that there's effective anti-resorptive therapy and compliance. So I look at this if I'm using a bisphosphonate to make sure that we're getting significant significant reduction in absorption. If I'm trying to titrate the dose of estrogens, I can use that as well. So the CTX can be very helpful. The other one is the P1NP, and this is the N-terminal end of bone collagen. So the nitrogen end, and again, you test fasting and in the morning. And the average for a postmenopausal woman is 45. And I use this to get an idea about their bone turnover rate. but also if I'm going to use an anabolic to see that it's working. You'd expect to see a jump of about 10 points when using an anabolic therapy. Bone turnover markers help you with compliance, to know that there's good drug absorption, that's effective. And for me, and I'll give you a vignette, a treatment of this, it helps me know when I need to give IV zoledronic acid again, or even an oral bisphosphonate again, if I'm on a holiday, if the patient's on a drug holiday. So zoledronic acid dosing interval, this is a pro tip. So zoledronic acid interval is typically 12 months for osteoporosis patient. And again, we talked about either 3 years or 6 years, depending on their benefit or if they have subsequent fractures. And it is FDA approved for osteoporosis prevention. And in that case, it's every 18 months. This interval, though, can be extended and personalized for each individual patient by using the combination of the CTX, is it suppressed, and the DEXA, is it improving or staying stable? So if the CTX is less than 300 and the DEXA is improving in the interval or stable, then it may be extended. You don't necessarily need to give it every 12 months in treatment or every 18 months in prevention. And if a person's in a drug holiday again, say they had their 5 years of oral bisphosphonates, you can continue to follow the CTX and DEXA and determine when they may need treatment again. If the DEXA is starting to fall off and the CTX is going up, that's a clear indication that they need to restart the medications. And again, compliance is important. So when I discuss the options with patients, I often talk to them about zoledronic acid, how I may not need to give it to them nearly as often as it's typically recommended to get an effective response in their bone health. And this is something that many patients are interested in. We do need to know about this adverse effect of zoledronic acid IV. Many of you probably have seen this in patients. It's called the acute phase reaction. And it occurs within the first 3 days of IV zoledronic acid. And the symptoms include fever, myalgia, flu-like symptoms. It happens up to 42% of patients on the first administration. Subsequent doses of zoledronic acid, the acute phase reaction is only 10 to 12%. That's important to tell our patients. The other interesting thing is, and I tell patients this too, I say, this is a clear side effect. It's uncomfortable. It usually goes away in a few days. I can help it. I have some ideas help reduce the likelihood of it. But if you have an acute phase reaction, you're likely to have a better response and less vertebral fracture. So I tell them that there's kind of a gold pot at the end of that rainbow. If they end up having it, though it's uncomfortable, know that it's going to help the bones even be stronger. But the acute phase reactions can be reduced significantly by hydration. So if they're really well hydrated before and after, and they take acetaminophen before and after, you can reduce the likelihood significantly. And that's what I see in my practice. I don't see a 42% likelihood of it. The other thing is you want to administer it over 30 minutes. So you give the same amount, but over a longer time. So you get a decreased peak in the amount in the bloodstream, and it tends to lessen the likelihood. So every time I write a prescription for zoledronic acid IV, I say administer over 30 minutes. Let me give you a case vignette here. So this is a 78-year-old lady who came in with negative 3.2 at the spine and negative 2.6 at the femoral neck. She was treated with teriparatide for 2 years. She had a great improvement, negative 2.2 at the spine, and I often see really prominent improvements in the spine, less at the hip, but still a prominent improvement. So the anabolics are particularly good at trabecular bone. There's more trabecular bone, as you probably know, in the spine than there is in the hip. And so the hip responds a little less prominently, but there was a terrific improvement there. Zoledronic acid was given immediately after completing teriparatide. We need to do that if we're going to have the anabolic. We need to then hold on to it with an anti-resorptive, and we give it right when it's done. So if they're the last dose at the end of November, the first dose of zoledronic acid would be in the beginning of December, right away. So at 12 months, her CTX was 175, so much less than 300, and her DEXA was even a little better than it was a year before. So she continued to have improvement. So the zoledronic acid was held. At 18 months, the CTX was 245. And at 24 months, the CTX was just over 300. The DEXA was stable, and I gave another dose of Zol. So that spread it out to 24 months. And this approach, as I mentioned before, can improve compliance and lessen side effects. And I'll tell you, in some people, I have them out 3 or 4 years between doses because their bone reabsorption is under 300. The CTX looks great, and their DEXA is stable. So I give it to them when they need it, and that just makes great sense to me. And I see that more and more nationally when I speak to other osteoporosis experts. Let's talk about other side effects with the anti-resorptive therapies, and this is really well out there. So we're talking about osteonecrosis of the jaw and atypical femur fractures. So over 10,000 years of 10,000 patient years of therapy, we're going to decrease the likelihood of we're going to reduce at least 100 fractures. Over that same time frame, there may be 3 cases of osteonecrosis of the jaw. And over the first 5 years, a couple cases of atypical femur fracture. We'll talk about those more in a minute. The longer you give the anti-resorptives, the bisphosphonates, and even denosumab, the risk of atypical fracture goes up. So at 10 years, it's about 10. But still, we roughly prevent 100 fractures for any fracture caused at 5 years of BSPs. So, and it's even less with denosumab. The lecture at the bottom is a community lecture given by an osteoporosis specialist at Stanford. This is a terrific lecture that would be available for you to get more information or for your patients. Let's talk about atypical femur fractures. So it increases with the duration of BSP or anti-resorptive therapy. It's 2 in 100,000 at 2 years. It's about 1 in 1,000 at 8 to 10 years. For every atypical fracture, about 100 fractures are prevented. So even though this creates a great deal of fear in patients, we need to help them understand that the likelihood of other fractures are just decreased in a very, very significant way. One of the things that take away is that if a patient has any pain between her hip and her knee, or his hip and knee, and they're on an anti-resorptive therapy, we need to get X-rays, because you may see and be able to prevent atypical femur fracture, which happens in the shaft of the femur rather than typically at the neck of the femur, which is the kind of fracture we'd see from a fall with osteoporosis. And you can see there's a periosteal reaction right here. There's a bump on the cortex there, and it's on the lateral aspect of the femur. And you can see these legs are a little bit bowed. And people who have a little bit more of a bow leg, there's more stress on this outer cortex. So that's a reason, that sort of anatomy will increase the likelihood of it's micro trauma there, and eventually it fractures. So this again shows a periosteal reaction here. And it was 3 months before this fracture, this atypical femur fracture here. So this patient may have been complaining pain in the hip or the knee or the buttocks or something like that. And that's the time to get the X-ray, because in this situation you can treat it. Sometimes we give an anabolic therapy. Sometimes they're even rotted as a preventive measure to decrease the likelihood of that. Okay, the osteonecrosis of the jaw, which you can see there. So the mucosa's worn away, it's not healing. You start to lose some bone as well. This is not a comfortable, it can be painful, but many times it can be treated well with good oral care and even prevent it. So the benefit of the approximate 40 to 70% reduction in fracture risk far outweighs the 1 in 10,000, the 1 in 100,000 risk of MRONJ or ONJ. And this is based on information from reports from the American Dental Association, the oral surgeons, and a task force on this. A tooth extraction or an invasive surgery may impart additional risk for MRONJ, especially if the person has underlying periodontal disease, chronic infection, is a smoker, excessive alcohol use, diabetes, cancer care. So if they're unhealthy and they have other medical concerns as listed, they have a higher risk. So the standard patient doesn't have that high of risk. Things like routine cleanings, filing, scaling, root canals, and even implants do not appear to increase the risk of ONJ. And this is a letter, see the website, the dental risk letter, and this is by the Bone Health and Osteoporosis Foundation. This is something that you could share with a dentist who may have some concern about the use of bisphosphonates. It pretty much summarizes what is above, but it's done in a professional manner that you could simply print and sign and send. Denosumab, rebound bone loss and vertebral fractures. This is a significant concern with denosumab. If you just stop denosumab, you can get rapid bone loss. So what we think happens is that denosumab really suppresses osteoclast, the rank ligand effect, et cetera. And then so we have these really hungry osteoclasts that are ready to go. So at 6 months, when the denosumab has fallen off, and the osteoclasts just become very hungry, and you get rapid deterioration of the bone, particularly in the spine. So there's this bottom line here where the arrow is. This is about 6 months, and the likelihood of a vertebral fracture happens really quickly, 6, 10, 12 months out, right? This dotted line is if a person has ever had a bisphosphonate beforehand. So if they had a bisphosphonate before denosumab, it's still in their bone and it decreases the likelihood of rapid loss. And if you give them a bisphosphonate at the time right when they're scheduled to get their next dose of denosumab at 6 months, if you give them a bisphosphonate, then the likelihood of these vertebral fractures, which sometimes can be multiple and cascade through the spine, can be reduced significantly. Conclusions. DMAB should always be followed by an anti-resorptive. There's no holiday. Bisphosphonate treatment should be started 6 months after the last DMAB. BSPs could be discontinued at 12 months if the CTX looks good and you follow them carefully. The longer the DMAB is used, the higher the risk. So if a person's been on it for a year or two, the risk has been very high. And if they've had a previous history of vertebral fractures, that really increases the risk. And they've already showed that they've had some issues with strength of their spine. If you stop the denosumab without further treatment, they may be at big risk for trouble there. Let's move to the integrative side of this, because this really has some benefits as well. So there's a synergy between exercise, nutrition, and medication in bone health. Exercise is really important. Strength and balance. People who are coordinated and strong, they don't fall as much. That's a big deal. Nutrition is really important, and it's got to do with eating colorful plants and protein, and much higher levels of protein, up to 1.2 grams per kilogram. We'll talk about that in a minute. These are the basic supplements. We'll talk about vitamin D, calcium, vitamin K2, collagen, soy, silica, taurine, and potassium. I'm not going to specifically talk about these in the next few slides because we don't have time for that. But silica, 10 milligrams a day, can help bone health, and it helps with hair too, by the way. There's data that, silica is high in beer, and I'm not recommending beer for bone health, but in data from the Framingham study, people who had a little bit higher incidence of beer drinking actually had better bones. Taurine is an interesting supplement that has terrific animal and some modest human data for bone health. I like taurine. And potassium citrate changes the acid-base balance. How it can decrease the likelihood of kidney stones. It also can improve bone health. We will talk about strontium, but you can see that I have a big red not recommended there. So exercise. Laura Gian Gregorio is a professor of physical therapy at Waterloo University in Canada. She is an expert, a North American expert in bone health. And she says that exercise should be first line, that walking is not sufficient, though it's great for health. It doesn't do a whole lot for bone health in particular. That progressive resistance training 5 to 10 reps of things like deadlifts and so forth in this make a difference. There was a wonderful study called Lift More where they actually had women in their 8th and 9th decade, so 70 and 80 years old, involved here, and there was a significant improvement. Jumping can be beneficial too. Not everybody with osteoporosis is going to be fit enough in their ankles, knees, and hips to be able to do that. But some of our younger patients that have osteoporosis really can do this. They can do some deadlifting. They can, with a trainer or a physical therapist, can help teach them. They can learn how to jump like the drop jump. You have them stand on a 12-inch box and just drop to the floor. That is an effective way to help build bone and strengthen the legs and so forth. So exercise is important, but also balance challenging exercises are really important. As you can see up here, these women doing Tai Chi. People that can stand on one leg like that tend not to fall as much, right? And they're going to have better control and strengthen their leg and hip muscles for less falling. But that's going to, also help their overall health. So exercise is really important, both lifting and balance challenge. You may have heard about OsteoStrong. It's available in a lot of communities. It's really sold as being something that's highly effective. Well, a recent review by Dr. Deanne Gregario, the same person that I mentioned before, in this little 5-minute YouTube video helps that. She reports that there's no randomized controlled trials reporting that efficacy on bone mineral density, that there are no randomized controlled trials that it's safe, and there are many better options. So we don't recommend it in general in the osteoporosis treatment realm. It's just, we don't think it's particularly safe or effective, but a lot of people are paying, to do this on a weekly basis, and that's not necessarily good. And we've also seen fractures of the spine based on OsteoStrong, so not recommended. Let's talk about protein intake. So 30 to 40 grams per meal is probably the optimal amount of protein to ingest if you want to build muscle and bone. It's related to the amino acid leucine. With that amount of protein, you get about 3 grams of leucine, and leucine turns on mTOR, which is a process that helps support muscle building and anabolism. The RDA is way too low. New data suggests that about 1.2 grams per kilogram, that's about 90 grams for a 150-pound person, is more likely to be effective. And in older adults, they have an anabolic resistance. There's not as much digestive power in the gut. The acid production goes down, enzymes go down. The muscles actually need a higher level of leucine to respond. So in older adults, even more. So this is more protein is necessary. A typical Western diet, a person may have 5 to 10 grams with a bowl of cereal in the morning and then a light lunch, and they'll get most of their protein at dinner. This is not the best way to do it. It's not as effective. Rather, it's much better to get about 30 grams per meal, because every time you hit about 30 grams, you give a signal to the muscles to build. It comes back down. You get another 30 grams at lunch. It gives the muscle a signal to build. Same thing at dinner. But here, both of these, you don't hit the threshold necessary in an older adult to build muscle. So this is the only opportunity here. So this is 26% more anabolic. And these here are examples of 30 grams of protein. So 4 ounces of fish or poultry or beef. It turns out you need about, 5 eggs, because an egg is about 7 grams of protein. You can get, with a certain amount of yogurt, you can get it, etc. Beans and lentils and things like this can be helpful as well. But it takes a good amount to hit that anabolic threshold to help you build bone and muscle. Vitamin D. Higher is not likely better. You want to hit a threshold. You want to limit toxicity. So you want to treat to target 40 to 50 nanograms per mil. Typically 1,000 to 2,000 IU is effective, though I certainly have patients that need 4,000 or 5,000 daily, and those who have had things like significant obesity or gastric bypass may need a lot more than that. Just an aside that vitamin D is effective at other things like prevention of acute respiratory illnesses. The number needed to treat there is only 4. So the other thing to know is that in an all-cause mortality graph, that the lowest all-cause mortality is when the vitamin D level is about 50. So that's what I aim for in most of my patients. Vitamin D3, somewhere between 2,000 and 5,000 daily. But I don't just go on the dose. I treat to their target, treat to their response, and a target of about 50. How much calcium? Well, lots of adults take calcium supplements and many take too much. The sweet spot is to get about 1,200 milligrams of calcium, mostly from food and possibly some from supplement as well. Food is the optimal source. It has a wide safety margin. And when you give a big dose of calcium, so you give 500 milligrams of calcium carbonate, you get a big bolus in the bloodstream, and that's really not the best way to do it. The average American gets about 600 in their diet, and if they're not having dairy, about 300. So you don't need to supplement that much to get them to the 1,200. Excess calcium can cause things like nephrolithiasis and hypercalciuria. We know that if you're giving like 1,700 milligrams a day, most people aren't getting that, but some people will get a great diet and then think they need to take 1,200 or more. Well, they might be getting that much. The Framingham study said that when you're giving a reasonable amount of calcium, that there's no increase of coronary disease or coronary calcifications, but there is an increase in kidney stones, so we want to be careful there. And of course, excess calcium in adults, older adults, clearly is a cause for constipation. So calcium carbonate could be supplemented 500 milligrams per tablet, but this requires gastric acid. So those that are getting older or are on PPIs, that's probably not the best choice. Calcium citrate is the one I use more likely, 250 milligrams, one twice daily or two daily. And the neat thing about calcium citrate is that it's actually the citrate itself, and I'll show you in a minute, actually increase the base environment in the body. So this is better for bones and better for kidney stones as well. And the expensive algae calcium is of no benefit. And people who have had gastric surgery, Roux-en-Y, or gastric sleeve may need more as well. Calcium sources, 276 milligrams in a cup of milk. But you can get a lot of calcium in other things, like in a cup of almonds you get 367 milligrams. In 5 dried figs you get 135 milligrams. In a cup of broccoli, 74 milligrams. So a whole food diet is going to help you get lots of good calcium too. Let's talk about collagen. This is based on this paper, Collagen Supplementation, a review of it. It is the most abundant protein in mammals. 30% of the total protein in the body is collagen. Collagen, 80% of skeletal protein, 95% is type 1 collagen. So collagen is really, really a part of our tissues and bones. Collagen is a triple helix, primarily made of 3 amino acids, glycine, proline, and hydroxyproline. That's why if you take, say, 10 or 20 grams of collagen a day, you don't add that into your total protein intake because it's not a complete protein. It doesn't have the full array of essential and non-essential amino acids. So don't count collagen if you're trying to get 100 grams of protein. Collagen is not part of that, though it can be helpful for your bones. Again, we know it's important for bones because the CTX is a C-terminal end of collagen. The P1NP is the N-terminal end of bone collagen. It is, by the USDA, considered GRAS, that is safe for ingestion, and it's rendered typically from bone and skin. Animal studies and human studies show increased BMD with collagen. Let's look at soy. So there's an isoflavone from soy called genistein, and 54 milligrams a day has been shown to improve BMD, improves bone turnover markers, that is, will reduce CTX. Genistein is a SERM, basically. It binds estrogen receptors, not as strongly as estrogen, but it binds them and can have a benefit for bone health. And it tends to decrease the risk of breast cancer, both the initial occurrence and the recurrence. So genistein is safe in women even if they've had breast cancer or have a risk of that. 27 grams of soybean gives you 54 grams of genistein. 27 grams of tofu would give you 54 milligrams, or you can simply take a 54 milligram capsule. There is a medical food. Medical food is something that has higher standards it has to meet for proof and effectiveness. And there's one that's called Fostium, and it has calcium and genistein and zinc and MK7 and vitamin D in it. This is expensive. I don't prescribe it because of that, but just to let you know, there's some real data behind genistein. Let's look at vitamin K2. This is an August 22 paper. It's a meta-analysis, and it showed that there was improvement in lumbar BMD, but no clear improvement in this study at the hip or the forearm. This is a study in the Journal of Bone and Mineral Research. Poor vitamin K status is associated with low bone mineral density in chronic kidney disease. So just to just show you that vitamin K is involved in bone health. And this is the most important study of the three. And this was a 2013 study that 180 micrograms daily in 244 patients followed for 3 years increased bone mineral density at the spine and the femoral neck. It increases osteocalcin. I'll show you the mechanism here. Vitamin K2. So you see K1 at the top, you see vitamin K2, MK4, and then vitamin K2, MK7. That's the one that's typically used these days. It's a longer, and what these are, there are certain proteins that are activated by vitamin K. And you know some of these are the clotting factors, and that's particularly important for vitamin K1. But vitamin K2 turns on two other proteins. It turns on osteocalcin, which increases calcium deposition in bones, and it turns on something called matrix GLA protein. And this actually decreases calcium absorption in the vasculature. So I use vitamin K2 not only in my bone health patients, but in my cardiovascular risk patients. So K1 is found in green vegetables. It's mostly concentrated in the liver, and it's involved in carboxylating the vitamin K-dependent factors 2, 7, 9, etc. Vitamin K2 is found in fermented foods, eggs, liver, activates osteocalcin, and then, like I said, that matrix GLA protein. Modest doses of vitamin K2 are safe. Higher doses may affect Coumadin-based anticoagulation, but thankfully these days we don't have too many patients on Coumadin. A little bit about acid-base. So acid, because it needs to be neutralized, can end up extracting base, which is calcium and magnesium from our bones, right? And amino acids like methionine and cysteine found in meats and in grains, by the way, are metabolized into sulfuric acid, so it changes the acid-base status. So you say, well, maybe we shouldn't be eating meats. Well, let's talk about that more. What we found out with vegetables, though, and fruits, they're potassium-rich, they're high in potassium carbonate and potassium citrate, and magnesium. Bone is and so this offsets organic acids that would potentially come from meats and other things. One molecule of citrate, like in the calcium citrate that we supplement with, or in citrate that comes from fruits and vegetables, is metabolized into 3 molecules of bicarb. So it's very effective at helping acid-base balance and supporting the mineralization of bones. As we age, we have an increase in acid load, partly because when we lose bone, we lose muscle, and glutamine is stored in muscle, and it's an acid buffer. So it's another reason as we get older that may lead towards sarcopenia. Grains also increase acid load. They're low in potassium, they're moderate in sulfur-containing amino acids, and so they're just potentially as problematic as meat. The hunter-gatherers were found to eat up to 250 grams daily of protein, but they had a very high plant issue, and they had, the best we can tell from the research, they had no significant osteoporosis issues. Meat, which supports bone and muscle accrual, or grains are okay if you eat enough plants, so you can eat both. But the bottom line is you're probably best to eat plenty of protein, because that's the matrix, the structure, the 2x4s of bone, which then get mineralized, and eat the vegetables to keep the base right, the acid-base status better. So just a quick review of nutrition and acid-base status. Strontium. Well, it turns out that strontium, which is in a lot of over-the-counter products, does have some favorable actions on bones. It decreases osteoclast activity. and it promotes osteoblast activity. That sounds good. And in a 3-year study showed a 41% reduction in new spine fractures. That sounds good too. However, it has some unfavorable actions. Strontium supplements for any period of time falsely elevated bone mineral density. That because strontium on the periodic table is right below calcium, and it's much heavier. So in the bones, it's denser, even though it's just one molecule of a mineral. So what happens is the bones look they have an inflated bone mineral density without an inflated strength. Research in Europe shows that strontium ranelate, which was a drug in Europe, increased the risk of MI, venous thrombosis, and serious skin reactions. The EMA, that is the FDA of Europe, the EMA, in January 14 no longer recommended the use of strontium. And then in the US, strontium citrate and strontium chloride available. And they've really not been studied for either efficacy or safety. There may be the same health concerns. So I routinely tell my patients not to use strontium, to look at the supplements they have at home. Many of the over-the-counter expensive bone health products will have algae calcium, again, which isn't that helpful, and will have strontium as well, which is, I think, potentially deleterious. So let's go into a couple of resources here. So the Santa Fe Bone Symposium in 2023 was excellent. And that website there that I listed has all of the lectures and it's free. And this is a clinical-based bone health conference. It's for providers, primary care providers like you and I, that want to get better at bone health. It's excellent and it's free. And it's been going on for about 20 years. Now, the next one's going to be in August of 2024. And though you can sign up for that virtually or you can attend that, typically in the month or two afterwards, those lectures will be free too. So this is a terrific resource. And this is a series of resources that are also very helpful. As part of my interest in bone health, I've been involved in this National Bone Teleecho program from the University of New Mexico every Tuesday, and I've been involved since 2017. I've learned a lot, and that's also available to interested clinicians. It's free. There's about 150 people that attend weekly on this teleconference, so you could do that if you're interested and really want to learn a whole lot more. But these are some key lectures from that program. It starts out with 20 minutes of didactic, and then there's case presentations. It's about an hour and a half long on Tuesdays. But these are key lectures. The first one is on ACE guidelines. The second one is a community lecture from Stanford. I showed you that before. The next one is by Dr. Binkley, who's world famous in regards to his understanding of vitamin D metabolism and also bone health. Ben Leader, the one we talked about before in regards to sequential approaches, and many other terrific lectures. One by Sarah Erb, another primary care approach to bone health. Paul Miller talks about controversies. Kelly Crone, who's an expert in anabolics, talks about atypical femur fracture. These are all free and online, and potentially really helpful for any of you that want to get a whole lot better at their bone health. And if you are, what we'll call you a bonehead then. That means you've really put your efforts in and you learned a lot about bone health. But this may help you help your patients. So if this is an interest, these are great resources. And finally, this is the ACE guidelines in an algorithm. I know that you probably can't read that very well here, but it's also available online, and you can put this, you can print it and have it by your desk, or just have it available on your computer. Last, I'm going to leave you with an optimal bone health patient information form that I use in the clinic. It talks about using vitamin D3 and K2, calcium citrate, collagen, genistein, taurine, silica, protein at about 100 grams a day. Walking is important for health for sure. Resistance training. And I like the rebounder, which is a way to jump fairly without too much stress on the system. You can start slow with that. So these are just this is just a basic information sheet I give to my patients. Last, I want to say, I think you got this. This information and the other education you've done and the experience you have, you can really help patients make a difference in their health, in their bone health, in their risk for disability and pain and other serious things by making the diagnosis and using the tools, the DEXA, the FRAX tools, and then offering treatments, and seeing what's right for the patient. It could be, medication if necessary, but it may start with great exercise and with some supplements, and then careful monitoring, finding out what the patient needs, what the patient's willing to do, and go from there. I wish you the very best in osteoporosis care and in your general practice.